Today we are going to showcase on 4 very interesting cases about transient hyperinsulinism. So we are going to focus mainly about the dilemmas in terms of diagnosing hyperinsulinism, especially the dilemma of 2 major endocrine causes of hypoglycemia, hyperinsulinism and cortisol deficiency. How they can interplay is what going to be the major part in that regard.
Case is 11-day-old male newborn, weight is 1.9 kg, born from the non-consecutive marriage, presented at the 8th day of life with multiple episodes of hypoglycemia since 8th day of life. For the complaint of the multiple episode of the hypoglycemia, child admitted in NICU and on the glucose requirement maximum at 8 milligram kg per minute. Birth history is non-significant. Full term, cries after birth, normal vaginal delivery. Birth weight is 1.8 kg. Child is SGA. After birth, child handed over to the mother under observation. Child taking feed well. General examination is normal. Activity is good. No any sign of sepsis.
This case is also SGA. This is the third case with SGA. The only difference is that the presentation is very late.
Very late.
Your case, Naveen, was 3rd day. This was 1st day. This is 8th day. So this is going to tell you something. Carry on.
On general examination, patient is vitally stable, not in shock. SPL is somehow lower side. That is a 2 centimeter, 1.9 to 2 centimeter. General examination is normal.
So this child was discharged and again readmitted as compared to the other one. So I think key thing here is that you have seen SPL which is enlarged, which is on the smaller side, and there is no hepatomegaly.
No hepatomegaly. Patient on GIR maximum 8 milligram per kg per minute. Further another history, there is no sign of sepsis. No history of maternal diabetes or no history of maternal intake of oral hypoglycemic agent or any medication. No any midline defect like cleft lid, cleft palate. No hepatomegaly, no ear creases, no organomegaly to rule out any syndromic causes and means persistent hyperinsulinism. No any atypical genitalia, no pigmentation, no dehydration, no any eye pathology to rule out some galactosemia either. By
Just hold on. So you have a case who has an 8-day onset of hypoglycemia with the micropenis as your major thing and SGA. These are the main things. So what are you going to think of in terms of?
Sir, because that this patient presented 8 day of life with no any intrapartum or peripartal significant history. It can be with a small phallic size that can be due to the multiple pituitary hormone deficiency, or it could be the cortisol deficiency.
So you're talking about a counter-regulatory hormone deficiency. Can this be a milder form of hyperinsulinism?
Sir, it can be.
So milder form of hyperinsulinism can still be there.
But birth weight is
prolonged hyperinsulinism, a milder form may be a contributory factor. So major thing that you're looking at is that GIR is not high, which is again important. So go on to investigations quickly.
On investigation, routine workup was done. That was normal. HB is normal. Sepsis screen was done. That is negative. Sodium is lower side. That is 130 millimole per liter. Potassium is somehow higher side, but it is normal, 5.3 millimole per liter. Calcium is normal, and another investigation is normal. So in summary, my case is 8-day-old child presented with multiple episode of the hypoglycemia with a low GIR requirement up to the 8 milligram per kg per minute with no any significant peripartal history or no any syndromic finding or no any stress factor. We advise for critical sample at time of the hypoglycemia. Blood sugar was 30 milligram per deciliter. We found that cortisol was somehow lower side. That was 39.49.
So this is nanomoles per liter, and this should be more than 550.
Blood ketone was higher side. That is the most important part of the history. Blood ketone is 3 millimole per liter. That is ketotic hypoglycemia. Sodium is lower side. Potassium is normal. And again, detectable insulin is 4.05. That is a higher side.
Now your case is just the opposite of what science is doing. This child, that case also had lowish cortisol and high insulin. Your child also has a low cortisol and a high insulin. Now, when you talk about these two possibilities, which is more likely in your case as a primary?
Sir, in my case, presentation is very low. That is 8 day of life plus ketotic hypoglycemia, that is 3 millimole per liter, and sodium is favoring that. The sodium is 130 millimole per liter, so more of it favor of the cortisol.
So later presentation, lower GIR, positive ketones, lowish sodium, although that sodium may be normal for the newborn period, and small phallic size. These all are favoring towards a multiple pituitary hormone deficiency as against a hyperinsulinism as the primary thing. But again, we say that any detectable insulin during hypoglycemia is significant. So why do you think this insulin is detectable?
So body perceives this as a stress, and any stress will lead to.
So this mechanism is not that much elucidated as you had discussed at why you have low cortisol and high insulin. But yes, if you have any form of perinatal stress or hypoglycemia, your insulin will go up. So what I'm trying to say is that don't just go by numbers of insulin or cortisol. Look at the whole picture. This child is typically telling you that I am cortisol deficient. Insulin is a byproduct. Science case was clearly telling us that this is clearly hyperinsulinism and cortisol is a secondary thing. So don't just go by numbers and what we say in the algorithms. Look at the entire picture. This whole picture is typical of cortisol deficiency. Now, why cortisol deficiency and all those things become another questions. Carry on.
Now, according to this history and investigation, we can summarize this child and we can put our differential diagnosis. First is seeing the small phallic size and cortisol deficiency. We can put it as a multiple pituitary hormone deficiency. Second is isolated cortisol deficiency. And by seeing the detectable insulin at the time of a hypoglycemia, we can put it as hyperinsulinism. What is the features favoring the MPHD? In MPHD, there is a small phallic side or midline defect like cleft lip, cap palate, low GIR requirement. Birth weight is normal, and maybe also in some case associated with the breech delivery. There is a hyponatremia with normal potassium, and ketotic hypoglycemia should be there. In prolonged hyperinsulinism or persistent hyperinsulinism, there is a large for gestational age baby, ear crease, hepatomegaly. Insulin glucose requirement is higher side, up to the 12 milligram per kg per minute. It present early and it having some delivery problem like shoulder dystocia, and ketone level is less than 2, mostly 0.6 in most cases.
This is clearly going more in favor of cortisol deficiency.
So further workup, we did thyroid profile and the testosterone that is normal.
So what do you mean by normal testosterone at this age?
Sir, it having the mini puberty, so it
was very high. So it was like 7 nanogram per ml, I believe. And high. LH was also high. Yeah. So this basically means he was well into mini puberty. So this basically means, this is for emphasize, that it was in a good pubertal range, so it excluded hypo. What are the two conditions in which you will have low LH and testosterone in mini puberty? Naveen. One is hypo. Of course, if you have hypo, if you don't have Kalaman syndrome, something like that. Second, complete androgenesis. Otherwise, anybody after the first week of life till around 6 months will have a LH which is at least above 0.7. But in most cases, it will be like male adult testosterone level. So he had actually the male level of male is 2 or 200 nanogram per day. So he was pretty robust response. And LH was also in a high level. So it was clearly, so it excluded HH. Now thyroid was normal, so that excluded that. We can't evaluate growth hormone excess very well at this stage, so we did not. Prolactin was not done, but MRI was normal. So now if you look at the entire picture, multiple pituitary hormone deficiency becomes less likely.
And as child having no any other features like cleft palate, cleft lip, and other hormone levels are normal except cortisol, so MPHD is ruled out. As child having detectable insulin, so hyperinsulinism could be the possibility. So we can keep now two possibility: isolated cortisol deficiency and hyperinsulinism. But as we see in the history, child having ketotic hypoglycemia with low GIR requirement, with no any feature suggestive of hyperinsulinism, like no any stress or no any history suggestive of persistent hyperinsulinism. So hyperinsulinism is ruled out. So we started patient on tablet Hyzon, and patient responded to medicine. In follow-up, patient maintaining RBS well, euglycemic, all blood glucose between the 100 to 150 or 125 milligram per deciliter. So Hyzon gradually tapered, growth is normal. So in plan, we give follow-up advice for repeat cortisol, sodium, potassium after 38 hours of stopping Hyzon.
Hyperinsulinism, first of all, you have to look for the causes of transient and prolonged hyperinsulinism. If they are there, you can manage them with dextrose and diazoxide. If they are not there, do not go for any genetic testing. Do a diazoxide response. And when we say diazoxide response, start with 5, wait for 4-5 days, go up to 10 to 15. No response is a failure. If there is a response, don't bother. You continue treatment. So I would say clinical management is very important. If you want to look at GDH, look at ammonia. Don't go for a genetic diagnosis. It's not going to help you, except maybe all these neurological features may develop. If, however, there is no response to diazoxide, go ahead and do a genetic workup for a potassium ATP defect. And this has to be ideally done in both parents and the child. If you see a recessive defect, so both alleles are affected, this child is never going to respond to diazoxide, needs a long-acting octreotide or a surgery. And this has to be a palliative surgery. You can't correct it completely. If, however, the defect is there in the father, which means there is an imprinting problem, and this would then suggest a focal form, do a fluorodopa PET. If you see a focal lesion, do a surgical resection. If you see a diffuse injury, diffuse region, it's again like the same, palliative surgery will be there. If you find no defect or Beckwith-Wiedemann syndrome, now remember, Beckwith-Wiedemann syndrome should improve over time and it may respond to diazoxide. But if it is not improving, they can still have a focal lesion. So you can then go forward in that perspective. So to summarize, first of all, exclude a transient form and a prolonged form. Once you have done that, start on diazoxide. Responding, no worries, do a ammonia level, which will give you the clue. Now, if there is no response to diazoxide, go for both mother, father, and child's potassium ATP channel defect. Recessive requires surgery versus a lanreotide. While if it is a imprinting form coming from the father, do a fluorodopa PET. If it shows a focal lesion, surgery, diffuse, palliative. If, however, you can't do a genetic test or the Beckwith-Wiedemann study is there, then you again have to do a fluorodopa PET. So this will really tell you when to do fluorodopa PET and when to do a genetic study. So vast majority, see, most of it will come here, will come like 80% will come here, maybe 10-15% will come here, 5% will require all that. So don't rush with those genetic diagnoses immediately, because you will have a confusion in that situation. So increased insulin effect should be considered if you have a high GIR, low ketone, hepatomegaly, hypokalemia, glucagon response, very important. High insulin levels are not essential. 18% of children with hyperinsulinism will not have even detectable insulin. So this is important. Very importantly, SGA, you have to think of a prolonged form. LGA, think of a potassium ATP channel defect. And diazoxide is the key. So you should have diazoxide and immediately start diazoxide and see the response, which will give you the clue in that perspective. So before we close, and we'll take some questions there, you can go and have a look at our website, look at our book is also available, and the application which will guide in that perspective.